Welcome everyone. My name is Dr. Monisha Bhanote, the founder of the Holistic Wellbeing Collective. Today I will be presenting a talk on the Integrative Approach to Fibromyalgia, From Pain to Ease. This talk is being presented on behalf of the Aging and Integrative Pain Assessment and Management Initiative. This is a comprehensive project addressing non-opioid pain management in adults ages 50 and older living in Northeast Florida. The overall goal of AI-PAMI is the advancement of innovative pain education and patient care throughout the development of provider and patient workshops focused on integrative pain management. Funding for this initiative is provided by the Florida Blue Foundation and the Florida Medical Malpractice Joint Underwriting Association. For more information, you can visit pami.emergency.med.jax.ufl.edu or contact the number or email listed below. I am honored to present this talk for the University of Florida, and let me share a little bit more about my professional background. I am a quadruple board certified Doctor of Medicine and published author with expertise in Integrative Medicine, Anatomic and Clinical Pathology, Internal Medicine, and Culinary Medicine. I have additional certifications in Culinary Medicine, Mindfulness-based stress reduction, Plant-based nutrition, and Yoga Medicine with Yoga for Cancer Recovery, where I apply a whole-body approach to healing. I'm an expert in the health and wellness, providing both speaking and written commentary to multiple news media outlets and publications. My interests include nutrition and the microbiome, the role of stress and inflammation in disease manifestation, and applying mindfulness as a lifestyle practice. In addition, cancer and disease prevention. My mission is to support an integrative approach to evidence-based holistic well-being. Today's talk will be broken down into the background of fibromyalgia, an overview of the pathophysiology and signs and symptoms, and then concluding with management and treatment options for both individuals living with fibromyalgia. A little bit about the history. So in 1816, Dr. Balfour described fibrous thickening in the muscles and connective tissues of rheumatic conditions such as lupus and rheumatoid via dissection. However, this is where confusion arose as people extrapolated that the same fibrous tissue in rheumatic diseases and inflammation in connective tissue was the reason for fibromyalgia. But this, as we know, later turned out to be false. We know fibromyalgia is a disease of the central nervous system, not of the muscles and tissues, connective tissue, as I will further discuss. From there, the term fibrositis was first used as a pathologic term, not clinical. And then not until 1981 was the first clinical study with just 50 patients published where the first time the term fibromyalgia was used. The challenge was that this is such a poorly recognized condition which cannot be characterized by abnormalities in blood tests. So with that, what is the term fibromyalgia? So fibro means fibrous tissues, myo means muscle, and algos means pain. Therefore, the term literally means muscle and fibrous connective tissue pain. It is estimated that 2 to 8% of the population, with women being affected 2 times more than men, are affected. The rates appear to be similar in different areas of the world. It is characterized by chronic widespread pain and a heightened pain response to pressure. Fibromyalgia is classified as a disorder of the pain processing due to abnormalities in how pain signals are processed in the central nervous system. The pain appears to result from processes in this central nervous system referred to as central sensitization syndrome. Fibromyalgia has also been associated with depression, anxiety, and post-traumatic stress disorder. So when it comes to the diagnosis of fibromyalgia, there is no specific blood test, and other diseases need to be excluded via their blood tests to incorporate the diagnosis of fibromyalgia. The American College of Rheumatology in 1990 designated 18 possible tender points that were involved. But the points are tender in everybody, so these points are even more tender in individuals being exposed to who have fibromyalgia. So these 18 tender points, which are demonstrated in the image, include under the lower sternocleidoid muscle, near the second costochondral junction, 3.2 centimeters distal to the lateral epicondyle, at the medial fat pad of the knee, in the insertion of the suboccipital muscle, the mid-upper trapezius muscle, origin from the supraspinatus muscle, the upper outer quadrant of the buttock, and at the prominence of the greater trochanter. Although these criteria were set forth by the ACR, these were set forth essentially so individuals could be enrolled in studies and we would have a basis for treatment. Even if individuals do not have these tender points, the most important finding is the widespread pain for greater than 3 months and and other symptoms. So essentially, the tender points have been eliminated. So the other symptoms were fatigue, poor sleep, cognitive problems, in addition to other symptoms. Now, newer provisional criteria were set forth in 2010, and these criteria require 3 things to be met. One is the widespread pain index and somatic symptoms, such as the fatigue, waking, unrefreshed, cognitive symptoms. 2 is symptoms need to be present for at least 3 months. And 3 is that the patient does not have a disorder that would otherwise explain the pain. So this 2010 provisional criteria eliminated the 1990 tender point testing. So the revised criteria would include the widespread pain index and symptom severity scale. This widespread pain counts for up to 19 general body areas noted as different highlighted areas that are these different colors in the image. Where the symptom severity scale rates the severity of a person's fatigue, cognitive symptoms, and unrefreshed wakening. So these are all calculated together to give a revised score or criteria. Now, as we know, fibromyalgia can coexist intimately with various other conditions. Therefore, we have to exclude these other diseases that may be present with similar symptoms. These may include hypermobility syndrome, where people who are super flexible seem to run into problems with widespread pain, endocrine disorders such as thyroid disease, cancer, autoimmune disease such as lupus, neurologic diseases such as MS. But with these diseases, we can usually run some additional tests and get a better idea what we are dealing with. So we can essentially exclude these tests so we can then get to a diagnosis of fibromyalgia. So what is causing the pain in fibromyalgia? The truth is, the pain pathway is very complex. It is very complicated, and there are a number of things which can modulate pain. So in order to understand what's happening in the pain response of fibromyalgia, let's do a quick review of a healthy pain response. There is a circulatory signal where the peripheral nerve receives a painful stimulus, and this painful stimulus travels up through the spinal cord. This consists of a central portion of gray matter dominated by the neurons and fibers and surrounded by a rind of longitudinally oriented myelinated fibers termed white matter. So this gray matter, which is represented by the little h in the pinkish area, is rich in neuronal cell bodies, neuroglia, supporting cells, and neuronal processes such as axons and dendrites. The white matter, which is demonstrated by the purple in the little cross section of the spinal cord, is rich in axons, myelinated, and then their supporting cells such as oligodendrocytes and fibroastrocytes. So in our image, the toe has a nerve. The pain signal is sent to the spinal cord. The spinal cord suppresses the signal. So only a small fraction of that signal goes to the primitive part of the brain. Now, once the signal hits the brain, there is another area within the brain that suppresses the signal even further, so that the conscious part of the brain where you are aware of it receives only part of the signal. So the original stub toe, by the time it gets to the brain, the signal is suppressed quite a bit and you're only receiving part of the signal. So this got us thinking, what is happening in an individual that has fibromyalgia? So first, scientists started looking at the periphery. Is the pain coming from the periphery, from that peripheral stimulus? So with that, scientists started looking at the bones, the joints, the bursa, the muscle, the tendons, the nerves, all these peripheral areas. And so what they found is that there was no abnormalities in the joints of individuals with fibromyalgia. So even when they started looking at these other structures, like, for example, is there tendinitis? Is there nerve damage? There was no reproducible evidence that any problem to structures themselves. So then they thought, all right, is the problem in the muscles? So looking at the muscles, they started looking at metabolic problems. So maybe there's something else going on here within the muscles of these patients. So a lot of studies were done doing muscle biopsies, looking at the metabolites of the muscles. And so far, there have not been reproducible studies to support this over time. So they found no muscle abnormalities with no degeneration or regeneration, no inflammation, and normal muscle metabolism. So then they thought, all right, let's look, maybe there's something happening more centrally. Maybe there's something in the nerve connection, in the spinal cord. And hints of this came when looking at the CSF fluid. The CSF fluid in individuals with fibromyalgia, there seems to be a very subtle difference in the neurotransmitters that were studied. So the CSF contained increased amounts of substance P. Substance P is released when axons are stimulated. There was increased nerve growth factor and decreased serotonin. So as no histologic abnormalities were identified, they started looking at these neurochemical levels, the elevated levels of substance P. When it is elevated, this increases the sensitivity to nerves, to pain, and even a heightened awareness of pain. So there was 4 independent studies that found that levels of substance P are 2 to 3 times higher than normal in CSF patients with fibromyalgia. Now, let's look at this again. Let's go back to our original picture and look at what is happening. So in this image, what we see is that all the inhibitory pathways are not there. So the pathway in the spine is essentially non-existent at the level of the spine, nor in the brain. So by the time the signal is hitting the brain, it is hitting it with full force. We don't have that inhibition happening. So the issue seems to be at the level of the spinal cord and how the nerves are sensing pain. This term is called central sensitization to pain. So now that seems to be what is the mechanism or the phenomenon happening in fibromyalgia. Now, this pain signal can come from anywhere. So let's look a little bit closer at central pain sensitization. So people with fibromyalgia have a lower threshold for pain because of increased reactivity of pain-sensitive nerves in the spinal cord or brain. The pain processing pathways function abnormally with hyperexcitability of pain processing pathways and underactivity or inhibitory pain pathways in the brain. This results in an effective individual experiencing pain differently. CPS is now considered the primary pathology in fibromyalgia and is supported by extensive neuroimaging research. At the University of Colorado Boulder, researchers used functional MRI scans to study the brain activity in a group of 37 fibromyalgia patients and 35 control patients. They were studied for exposure to a variety of non-painful visual, auditory, and tactile cues, as well as painful pressure. Functional connectivity on MRI between areas of the brain involved in pain processing and interpretation, such as the dorsolateral prefrontal cortex, anterior cingulate gyrus, amygdala, hippocampus, insula, and others, were different in fibromyalgia patients compared to healthy controls. The researchers discovered a brain signature that identifies fibromyalgia sufferers with 93% accuracy, a potential breakthrough for future clinical diagnoses and treatment of the highly prevalent condition. Although the precise etiologic and pathophysiologic roles of alterations in the neurophysiologic, immune, and neuroendocrine functions are unknown, their existence helps to dispel any notion that fibromyalgia is purely a psychologic disorder. In the neurologic function, we see reduced levels of hippocampal N-acetyl-aspartate, elevated levels of glutamate, reduced levels of GABA, and altered functional connectivity. In the neuroendocrine function, we see elevated levels of CSF substance P, as already mentioned, impaired growth hormone secretion, excessive sympathetic autonomic tone, and reduced IGF levels. And in immunologic function, we see elevated levels of interleukin-8 in the CSF, altered lymphocyte corticosteroid receptors, and a decreased T-cell activation marker expression. So from all of this, what we can understand is that it means pain signals can essentially come from anywhere. And since this is happening at the level of the spinal cord and the central nervous system, with this in mind, we have to keep in mind that signs and symptoms can vary as well. So in individuals with fibromyalgia, we have chronic widespread pain, fatigue, tiredness to a degree that normal activities are affected, sleep disturbances, heightened pain response to tactile pressure, cognitive problems, also known as fibrofog, with impaired concentration, problems with short and long-term memory, short-term memory consolidation, and diminished attention span, tingling of skin rashes, prolonged muscle spasms, weakness in limbs, even functional bowel disturbances such as irritable bowel syndrome, constipation, and bloating, urinary problems, chemical sensitivity, and some people even report restless leg syndrome, bowel and bladder problems, numbness, tingling, sensitivity to noise, lights, and temperature. So you can see there's a variety of symptoms that can be present. So that's why it is so important to exclude other causes that can be diagnosed by laboratory evaluation. Now, the symptoms can also be both aggravated and relieved by certain factors. So aggravating factors may include cold or humid weather, fatigue, a sedentary state, anxiety, overactivity even can be aggravating for some individuals. Now, there are some relieving factors. These may include a hot shower, being active, warm, dry weather, and massage. So really, people want to know, and patients want to know, what is causing this? What exactly is going on? And although we've mentioned the process of CPS, they really want to know a little bit more. And unfortunately, the answer is not very satisfying. But we do have some clues. Even though the etiology of fibromyalgia is unknown, we do know that there is a combination of genetic and environmental factors. So what are these factors? First, that there is a genetic vulnerability. There are a variety of genetic studies done over the years that show that there is genetic predisposition or vulnerability. So you can find variations in genes or polymorphisms that predispose an individuals to pain, and some of these mutations run in families, but not always. It has been associated with polymorphisms of genes in the serotonergic, dopaminergic, and catecholaminergic systems. But these are also seen in allied disorders such as chronic fatigue and IBS. Individuals with 5H2A receptor or 102TC polymorphism are also at increased risk of developing fibromyalgia. Additionally, emotional trauma, violence, stress, loss can be effective as precipitating trauma of a loved one or having worse symptoms after they have lost a parent or a child. Occasionally, there is distant history of sexual trauma, so whether there is violence or sexual trauma, this can be a contributory factor. Additionally, physical trauma. So when people develop fibromyalgia after a traumatic experience, such as a bad motor vehicle accident or a serious infection, people just feel lousy. So what's important here is that careful history taking often reveals a significant stressful trigger event or period, such as an accident, flu-like illness, emotional stress, overwork. These can precede the onset of symptoms. So trauma as a risk factor. There was a study performed by Haviland which sent out a questionnaire. About 20,000 questionnaires were sent back and about 10,000 were returned. And we found that there was a traumatic experience that was present as exposure in these individuals, and that traumatic experience changed the chemistry of the brain. These traumatic experiences were anything from, life-threatening emotional abuse, physical assault, sexual assault, major life stressors. And then additionally, where does obesity play a factor in this development of fibromyalgia, especially as we know the rates of obesity are increasing? Obesity is seen to be a risk factor due to the production of inflammatory cytokines, other painful conditions, and related to sleep apnea. A study performed by Moore and Nielsen also identified a dose-dependent association between sleep problems and the risk of developing fibromyalgia. By disrupting stage 4 sleep consistent in young, healthy subjects, the researchers were able to reproduce a significant increase in muscle tenderness. So poor sleep results in a decrease in insulin-like growth factor and human growth hormone, resulting in decreased tissue repair. So with our psychologic factors, we know that there is strong evidence that major depression is associated with fibromyalgia and other pain conditions that have substantial similarities in these neuroendocrine abnormalities, psychologic characteristics, and physical symptoms. So even with the precise mechanism of fibromyalgia remains complex, there is some hope in the fact that patients with fibromyalgia do respond to a variety of non-pharmacologic interventions. There is no universally accepted treatment or cure, and fibromyalgia is not a disease, as it is more of a state of being. So symptom management is really important in the treatment of fibromyalgia patients. The use of integrative approaches is even more important, as drugs used for fibromyalgia really only result in a 20% reduction in pain. This means that pain goes from a level of 10 out of 10 to 8 out of 10. And with each of these medications comes possible side effects. So our integrative multidisciplinary approach to fibromyalgia includes the physician understanding the patient. Research indicates that patients experience invalidation as harmful and mistrust, actually lowering the quality of life among fibromyalgia patients. So actually providing affirmation and general listening can be therapeutic for these patients. So when we're looking at this multidisciplinary integrative approach, we look at medications. Now, caution is recommended with medications. As we know, I've already mentioned that they only really result in about a 20% reduction in pain. When medications are used, they are affecting things at that spinal cord level with neurotransmitters. Most of these medications are antidepressants, but now remember, these antidepressants do not come without their side effects. Some of the ones that are often used includes with their names, Cymbalta, Lyrica, Elavil. Now, those side effects can last even longer. So they might be something like dry eyes. And in the long term, this is not going to have the best outcome for these individuals. Also, looking at sleep is part of the integrative approach. So we want to see what else can we do when we're looking at individuals. Sleep would be included. Getting enough sleep is critical for these individuals. So having good sleep hygiene is an important aspect of the integrative approach. We previously linked sleep as a risk factor. So the goal is to get enough quality sleep. So looking at sleep hygiene with a structured wake and bedtime, a comfortable environment, comfortable temperature, reducing electronics. Then additionally, we also want to look at nutrition. Now, there is no convincing data that any one diet will reduce pain, but we do know that people with fibromyalgia, when they have a higher BMI, results in obesity, and obesity is linked with fibromyalgia. And when patients with fibromyalgia lose weight, they actually improve their function. So an anti-inflammatory diet with high antioxidants may be beneficial based on evidence of increased oxidative stress and reduced antioxidant enzyme activity in fibromyalgia patients. Now the body. Poor physical fitness is associated with increased symptom severity in fibromyalgia patients. We do need to keep in mind post-exercise fatigue and pain and tenderness are frequently severe and can lead to a cycle of muscle disuse. So what can we do about this? Having a specific exercise routine which is within the physical capabilities of the individual is very important. And this intervention might look like walking for 5 to 10 minutes, aiming to increase to 60 minutes. And this might even take about 6 months for the individual to get there. Other exercises might include the elliptical or the bike or swimming and even stretching, as individuals do have a lot of problems with stiffness. So a stretching program twice a day, ideally with the tight muscle groups around the neck or buttocks, might be helpful. Additionally, evidence suggests that Eastern movement practices such as Tai Chi, yoga, Qigong, including the meditative component, may reduce pain and improve function in patients with fibromyalgia. And then lastly, the mind. Chronic pain leads to a lot of negative thinking and anxiety and not coping well. So we do want to consider something like the educational component behind cognitive behavioral therapy with goal setting, relaxation training, identifying the dysfunctional thought patterns. It has been shown that a 6 to 8 week trial of cognitive behavioral therapy seems to actually be better at improving the quality of life for patients with fibromyalgia than pharmacotherapy. So where is the evidence when it comes to integrative approaches? Now, there is moderate evidence for efficacy when it comes to aerobic exercise. We do have to keep in mind that too much exercise can cause flares. So we still need to determine the intensity, the most effective type of exercise, duration, and frequency. Additionally, CBT or cognitive behavioral therapy and patient education has moderate evidence. There is also weak evidence for efficacy with strength training, acupuncture, even hypnotherapy. Even though the studies for acupuncture are in the weak evidence, we do find that electroacupuncture may be better than manual acupuncture for fibromyalgia patients, and it is relatively safe to be recommended. The least amount of evidence is around chiropractic therapy and massage. So where does the evidence for yoga and mindfulness fit in? Now, there are a number of studies around the practice of mindfulness and yoga, and they show promising results, and I'd really like to review some of them with you. So yoga is one of the more commonly recommended forms of exercise for fibromyalgia. It can be a way to get a gentle stretch into the body and loosen the tight muscles. It helps with balance and strength. And as one becomes more advanced in the practice of yoga, it can also provide a good cardiovascular workout. The emphasis is on breathing and awareness, and it also helps calm and focus the mind. So after a review of evidence-based complementary therapies, there were 5,489 records identified through a database search. From those, 3,829 records were excluded after title and abstract screening, with 61 full-text articles assessed for eligibility. Finally, only 25 studies included complementary therapies, which ranged from nutritional, herbal, meditative movement, chiropractic, massage, hypnosis, guided imagery. So then when we looked specifically at yoga and mindfulness, the studies were even less. However, several studies reviewed and meta-analysis of available literature published between 2012 and 2015 did find a small positive effect on fatigue in multiple fatigue-related conditions, including fibromyalgia. There was also positive effects of mindfulness activities in depression that is comorbid with fibromyalgia. Meditative movements such as yoga, tai chi, and qigong reduced sleep disturbances, fatigue, depression, and functional limitations. So looking in detail at a pilot study, an 8-week pilot study that Henard did looking at Hatha, yoga, and mindfulness in the study, 11 participants found improvement in overall health status. These improvements include in stiffness and in anxiety and depression. Significant improvements were seen in reported number of days where they felt good and number of days of missed work. There was non-significant improvements in measures of pain, fatigue, and how one felt in the morning. So the study did support the benefits of yoga and meditation. However, further research was still needed. This is where the Effective Self-Awareness Program, which was a randomized control study of 45 women, with 24 in the intervention and 21 on the wait list. This intervention included a one-time physician consultation of 90 minutes, followed by 3 weekly 2-hour group sessions over 4 weeks. The curriculum adhered to education regarding psychophysiologic model of chronic pain, a written emotional disclosure about stress, where the individual had 30 minutes of homework of daily writing about stress and emotions in journaling. And the effective awareness techniques consisted of daily CD-guided exercises encouraging mindfulness towards one's breath, body and emotions, non-judgmental awareness of these emotions, and affirmations of self-acceptance, self-healing. Re-engagement in activity consisted of increased physical and leisurely activities and to not allow pain to dissuade them from engaging in very important relational experiences. The final session, the physician contacted each participant to address any remaining concerns and encourage further practice. The results of the ASA program demonstrated benefit for significant symptoms and perceived function for fibromyalgia patients. The intervention group had significantly lower pain severity, higher self-reported physical function, and higher tender point threshold at 6 months compared to the control group. Therefore, anecdotal evidence supports increasing emotional awareness as a way to mitigate chronic pain. More research is needed, but mechanisms responsible for the benefit of the ASA intervention are not clear, but these are generally low risk and low harm interventions. Now, the Yoga of Awareness pilot study of 53 women age greater than 21 diagnosed with fibromyalgia according to the ACR criteria for at least 1 year and stable with prescription or over-the-counter medications. Here, 25 women participated in a yoga awareness program and 28 received standard care. The yoga program included 8 weeks of 40 minutes of classes, including gentle stretches, 25 minutes of a mindful meditation, 10 minutes of breathing techniques, and 25 minutes of a group discussion. The yoga sequence was specific, including self-massage, warm-ups, tabletop mountain with sun arms. So there was a very specific protocol there. And what they found was that the Yoga of Awareness study was with low intensity, low impact yoga poses. The study found that with this home practice that was encouraged with posed illustration handouts, the assessment of improvement of pain and physical tests of their tender points, women who were assigned to this yoga program showed significantly greater improvements in fibromyalgia symptoms, including levels of pain, fatigue, and mood. Therefore, the research suggested the yoga intervention led to be a beneficial shift in how patients coped with pain, including greater use of adaptive pain coping strategies. Now, follow-up of this yoga awareness study evaluated the same intervention in a waitlist group and to test the intervention's effects at a 3-month follow-up in the immediate test group. Post-treatment results in the wait group mirrored the results that were seen at the post-treatment in the immediate group. Plus, follow-up results showed that the patients sustained most of their post-treatment gains at 3 months. Yoga practice rates were good, and more practice was associated with more benefit for a variety of outcomes. This study then indicated the benefits of yoga for awareness in fibromyalgia is replicable and can be maintained. Now, there was also another study done, a randomized control study looking at myofascial release, with the aim to see the benefit of applying a self-myofascial release technique on health-related quality of life in individuals with fibromyalgia. The study consisted of 66 participants. 33 were in the intervention and 33 in the control group. The intervention group participated in the program for 20 weeks. The study assessed the impact on cervical spine, shoulder, and hip range of motion and self-reported disease impact. Significant changes in measurements of the day per week, feeling good, pain intensity, fatigue, stiffness, depression, sadness, range of motion and neck flexion, neck extension, lateral neck flexion and rotation, shoulder flexion, and hip abduction were noted. Subjects responded to long-lasting pain relief 1 month and 6 months after the session. Therefore, the conclusion is that self-myofascial release can improve health-related quality of life, provided that a regular structured practice is carried out. So then that raised the question, is fascia the missing link in fibromyalgia? This proposes that inflammation of the fascia is the source of peripheral nociceptive input that led to central sensitization. Now, we know fascial dysfunction is proposed to be due to inadequate growth hormone production and HP axis dysfunction. Fascia is richly innervated, and the major cell, the fibroblast, has been shown to secrete pro-inflammatory cytokines, such as interleukin-6, in response to strain. Recent biopsies showed that increased levels of collagen and inflammatory mediators in connective tissue surrounding the muscle cells in fibromyalgia patients. However, this hypothesis has yet to be confirmed. Now, the question is there an interest in yoga among fibromyalgia patients? There was a study set out to inquire whether or not individuals wanted to engage in yoga practices. This was with a 13-question survey sent via the internet. There was 2,543 respondents from the United States, Canada, Australia, UK, and more than 24 other countries. The most cited benefits was that it reduced stiffness, relaxation, and better balance. The most frequently cited obstacles were that there was concerns about poses being too physically demanding, fears that the poses would actually cause more pain. So what this study supports is that there is a need for yoga programs to be tailored for fibromyalgia patients to include modifications of poses to minimize aggravating movements, and training in meditation and other yoga-based coping methods to minimize pain related to fear. The limitations of this study was that only individuals with internet were able to access the survey, and that the survey did not attempt to confirm the diagnosis of fibromyalgia by the physician. However, these yoga studies to date have no reported adverse events. So in summary, fibromyalgia is likely due to, in part, to altered pain processing in the central and peripheral nervous systems. Additional pathophysiologic factors, including genetic predispositions, autonomic dysfunction, and emotional, physical, and environmental stressors are present. Fibromyalgia is neither degenerative nor fatal, but chronic pain is pervasive and persistent. So a prevention prescription can be included in a plan for a fibromyalgia patient. This may include exercise to maintain a normal body weight, combine aerobics, strength training, and stretching, consider Tai Chi and yoga, and make exercise a time to play. This might also include eating a healthy whole foods diet rich in plant sources of antioxidants, avoiding trans fats and excessive caffeine, alcohol, sugars, MSG, and aspartame. And then, of course, honoring your temperament and sensitivity, learning more about yourself and your unique needs and values in work and relationships, journaling to stay in touch with your inner feelings and to give voice to negative feelings and stressful events when they arise, putting yourself on a list of things to take care of every day, considering regular massage therapy and or other body work, learning to meditate and practice daily. Mindfulness-based stress reduction course is recommended for structure and support. And then allowing yourself creative outlets such as art, music, dancing, or creative outlets. And then living for your own heart's desires. Give yourself permission to figure out what these are. Future directions on research can include better designs for studies and larger study groups. There is a need for standardized methods, terminology, and reporting of details to make replication and comparison more effective. There is a need also to evaluate the long-term effects on health in this population, how long positive effects are sustained, and to determine if there are synergistic effects of yoga and other management therapies. As we improve study designs, we will know more about how effective yoga is and how effective other integrative approaches are, which ones will benefit individuals most in fibromyalgia, and which ones will respond the best. I would like to thank the Aging and Integrative Pain and Assessment and Management Initiative and the Florida Blue Foundation and the Florida Medical Malpractice Joint Underwriting Association for the opportunity to present this challenging yet important disease. My name is Dr. Monisha Bhanote, and I want to thank you for attending and listening to this talk, and have a great day.